We move on to the next panel discussion on borderline findings on a targeted anomaly scan, how to counsel the parents. May we please have Dr. Vivek Krishnan and Dr. Bijoy Balakrishnan as moderators. And for this discussion, we have as panelists Dr. Amarnath Bide, Dr. Manigandan, Dr. Vidya Lakshmi, Dr. Danya, Dr. Sangeeta Menon, Dr. Reeti Rajan.
Well, thank you and welcome to all our esteemed panelists. None of them need an introduction, so I'm not going to take the effort to introduce each one of them, but all of them are familiar faces to you and you've listened to them over the last couple of hours. So basically this panel discussion is meant to discuss borderline findings on the anomaly scan. So what exactly are borderline findings? These are just findings that are in the gray zone, which is neither clearly normal, nor can you say definitively abnormal, go and terminate the pregnancy. So those ones on the edge are what we call as borderline findings, and may not be themselves pathological, but could indicate that there's something underlying that is a little off. So that is what we mean by borderline findings. And to give you examples, if you look at the central nervous system, sometimes at the anomaly scan you find a ventricle dimension of around 10.4 millimeter. So till 10 is normal. What do you call it if it is 10.1 or 10.2? Sometimes cisterna magna, again till 10 is normal, you find 11, 12. You might find a CSP that is looking a little narrow or a little wide from usual. If you look at the CVS, you might find an echogenic intracardiac focus. Sometimes you find what is called as a persistence of the left superior vena cava. And again, a right ventricle that is looking slightly bigger than the left or vice versa. If you look at the GIT or GUT, you might find an echogenic bowel. If you look at it in terms of the liver echogenicity, it looks slightly brighter, but not as bright as bone. Sometimes you find that the stomach bubble looks a little bigger than usual. So all of these are borderline findings. Again, early onset growth restriction that's right on the border. Fence sitter like 10 centile, 9 centile if I measure, probably 11 centile if Dr. Bijoy measures. So all of these are what we mean by borderline findings. Again, the soft markers. They're called soft markers for a reason because they do not directly indicate that there is a problem, but might be pointing to something more sinister if you go ahead and investigate. You can also have borderline findings in twin pregnancy. For example, an MCD pregnancy at around 20 weeks or 21 weeks, you find that there is maybe if you want to call it the stage 1 TTTS, maybe there is not. Again, if two operators see, one might think that there is a stuck twin, the other might think, okay, there's 2.2 centimeter liquor in that sac, so it may not be TTTS. So these are your fence sitters, and that's what we're going to discuss. I mean, we do not have time to discuss each and every entity listed here, but we've handpicked a few from these, and we have picked up cases from both of our experience and tried to put it together in the form of 4 case discussions. So the rules of the game for our panelists, we'll have 3 or 4 cases as time permits. These are not rehearsed questions. We're not going to target questions at you. Anyone can answer. Feel free to disagree, which in fact we want you to disagree, argue or counter. And if we have time at the end, we'll allow expert opinions and audience interactions at the end. So that was about the rules. Now the first case, shall I start?
Yeah. Just one thing I wanted to say about the last panel actually. In the last panel, we were always worried about the fetus dying. But how come nobody called the fetal medicine specialist? So whether it was diabetes, whether it was cholestasis, whether it was fetal anemia, whether it was twins, just pick up the phone and call us.
10 times a day, and in this panel she didn't even remember our department.
Because when we have a panel, we have obstetricians involved. Because we are trying to convey our message across to the obstetrician, but sometimes our voice is not heard. Because whether it is diabetes, whether it is cholestasis, whether it is twins with growth restriction, we have a very strong role to play in allaying your fear as to whether this baby will die or not. So if we tell you, for example, for the diabetes case, if you had an ultrasound report saying CPR is pathological, none of you would wait till 38 or 39 without knowing that report has got no value. Yeah. So that's the importance of a fetal medicine specialist there. So whenever we are taking a decision on timing of delivery, there is no person who can help you better to understand the fetal condition than a fetal medicine specialist.
Yeah.
Whether it is preeclampsia or whatever.
No, even in the rhesus negative, we would have probably done a transfusion at 34 and taken her till 37.
The crux of the question in RH isoimmunization was the closing hematocrit. What
Yeah.
was the closing hematocrit so that we can know the rate of fall and we can predict at what point this baby will have anemia and MCA PSV has got no value because after you have done 2 transfusions, MCA PSV is not going to tell you anything. Okay, even one, it is suspect beyond 34
He
weeks.
is worried.
Yeah.
Shall we
So
go to the scenarios?
having said that, let us proceed to the panel. And
Yeah.
here we need obstetricians, and because we are playing both sides of the game, we need obstetricians to help us get this pregnancy through. So we are a team. So remember that we are there next door.
Even if you don't want us.
Yes.
അതന്നെ. നമുക്ക് ഫീൽ ചെയ്ത് പോട്ടെ കഴിഞ്ഞു അടുത്ത മോഡൽ.
Next. And yes, we are counting on Vidya Lakshmi madam to put some controversy into this panel.
അല്ല മണികണ്ഠൻ പറഞ്ഞിട്ടുണ്ട് മിണ്ടരുത്.
No, madam is one person who can done. You can do a panel with her alone.
She'll be arguing with
No,
us.
what I told Vivek,
Yeah.
if I don't agree with her, she should not threaten me or beat me up. That's what I told.
സംഘഗാനം ഒറ്റയ്ക്ക് പാടുമെന്ന് പറയുന്നവരാണ് മാഡം. You can run a whole panel. Yes. So let's get to the cases. The first case is a 27-year-old second gravida, conceived during lactation amenorrhea. The NT scan was not done because she never knew that she was pregnant. Came at 20 weeks for an anomaly scan, and you find this. Anybody wants to say what is the finding here? Of course, you find renal pelvis, but the
Echogenic kidneys.
yes, so this is not how you see normal kidney. You don't see normal kidney so brightly, okay? So this is the liver. You cannot make out anything about the liver. If you see a kidney that's looking much brighter than the liver, then that is what we call as echogenic kidneys, okay? So this is echogenic kidney. So we are worried there's something wrong with the kidney. So then next thing I look for is the bladder. Bladder looks normal, which means the urine production is still happening. There seems to be good liquor around it. The stomach bubble looks a little prominent, but measures within normal limits, and you see normal liquor. So basically, if to summarize the findings, you have what we call as bilateral echogenic kidneys, brighter kidneys, a prominent stomach bubble that looks prominent but measures normal. You have normal bladders and ureters, and touch wood, the liquor until now is normal. So now you put this finding across to the couple, and I tell them your baby looks to have echogenic kidneys, and she asks you what does that mean? Can you explain this in simple terms? Because we don't understand your echogenic kidney jargon.
Echogenic kidney, I would tell the patient that the kidney is looking brighter than normal. So I think it could be because of different reasons, I would tell her. And the baby needs further workup to know the same. So since this patient has not undergone a chromosomal screening in the first trimester and all, I would like to send her to a fetal medicine specialist to
Okay.
get the baby evaluated properly. Look
Thank
for
you.
any, look for any soft markers, any structural anomalies, and definitely keep this baby under follow-up. Look for any
Right, so
evolving
we'll come to
problems
that. I
and
just
all.
want to know what you would explain to them in terms of what is echogenic kidney. Just means it is
Echogenic means it is brighter than
than
what
usual,
is
right?
normal,
Yeah.
and the baby needs further workup.
Right. So now the question is, agree it is bright, but what could be the reason why my baby's kidneys are brighter? Yeah.
There could be multiple reasons why this can happen. It could just be a transient finding, or it could be a pathological finding.
Okay.
So a transient finding can just go. It could just be normal in the next scan,
Okay.
which we have to follow up.
Okay. So that's basically because of the immaturity of the developing
immaturity
kidneys.
of the
Okay,
kidneys.
right.
The pathological reasons can be because of an infection or because of some ARPKD, ADPKD, some kind of dysplasia, renal dysplasia, which
Okay.
would need further workup.
All right. Even if there's an obstruction, sometimes you can have back pressure changes affecting the kidneys. Right. So now from this list, if the couple asks you, okay, you said a whole. Yes, ma'am. Yes.
Why we don't have genetics in this?
You have. I mean, it was we typed it in, but it got deleted. In fact, when we discussed in the morning, both of us included the CNVs as the first one, but I think the final version that's there in the system has it deleted. So amongst the pathological causes, you're right to point out that the first thing would be abnormalities in chromosomes or copy number variations. Yeah, so from this list, what could be the reason in our cases? What's the next question that's going to come from them?
So before we even go to the list, the
Yeah.
moment we identify bright kidney,
Yes.
so then a protocol is initiated.
Okay.
You look at everything again in the baby
Yes.
with subtle, focusing on subtle things,
Yes.
palate, an extra finger, go back in the
Okay.
head.
Nothing
and see
else.
everything.
No other structural anomaly.
Everything is clean, liquor is good,
Mm.
and the kidney size is normal.
Mm.
Then I ask the further question, in your case, it's bright with enhanced CMD. Corticomedullary differentiation is enhanced,
Yeah.
as opposed to lost or reversed. The lost or reversed will have a bad prognosis, whereas an enhanced CMD, before investigation, there's a 3 out of 10 chance that
So
it will end up.
if I put that picture up for you, Mani,
Yeah.
can you please explain what you mean by CMD?
Yeah, you can see that the cortex, which is the peripheral lining,
This
is
one?
bright. Yeah.
Yes, yes.
Your pointer is not seen.
Oh, okay.
Uh, Command L.
Yes.
Yeah.
We have a double engine here, so
Yeah.
helps.
So when it is brighter than usual and the differentiation becomes markedly obvious, then it's a enhanced CMD. As opposed to a reversed, which is mostly genetic, and a lost CMD. Everything is totally white. Then we keep thinking in terms of obstructive uropathy. So
Okay.
here, about 3 out of 10 chance that we will find something abnormal, and the vast majority of that would be a, as you said, CNV, copy number variation, especially involving 17q12, which may not have other findings.
Okay.
So
Does this combination large stomach, polyhydramnios, echogenic kidney?
Poly has not yet come, I
Normal
believe.
Liker.
So Liker was good.
Okay.
The stomach bubble being prominent, if it measures
Yeah,
more
question
than
is normal.
99 centiles in more than 2 axes, then I would call it. As subjectively, I hold it back. Many times we see that.
Yes.
So first is extended examination of the fetus.
Okay.
Then set up a systematic evaluation, which will include putting a needle and then seeing the baby back again after some time. So these two will be there.
Okay. So what happens in most cases? You say all this to the mother and to the couple. They're completely dazed. They've come expecting to see a normal baby and a normal scan report, and you say there's a finding which you yourself are not sure what this is, whether it's going to have a good outcome or not. Obviously, the next question is going to be: should we terminate the pregnancy?
Sangeeta ma'am, you want to take it? Are you going to terminate her now?
definitely not.
Not at all. Big
Completely
emphatic
normal
no.
fetus otherwise, just a borderline finding in a
No, no.
Forget about echogenic kidney. I just put it as a representative
Whatever
case.
it may be, at this point of time, there is no indication to terminate this pregnancy.
How many weeks of gestation is she? Just
She is 20 weeks, 2 days.
20 weeks.
Still fair enough.
Even if she was just, let's say, 18 weeks, or even if she was 22 weeks, we're well now because the MTP rules have been stretched to 24 weeks.
yes.
There is a whole gamut of women who come with small ventriculomegaly, small things saying that this is abnormal, I want a termination.
Yes. So do we all agree that if you have a borderline finding like this, we would not straight away recommend termination at
The
no point?
other
Yeah.
question I have is, suppose this patient wants to terminate because she does not want to take any kind of risk. So is she well within her rights to do that?
Yes, she is.
So
She is.
if she comes to you and says that, okay, I have Googled up echogenic kidneys, I know that it might be normal, but there is a what is it,
Small.
5% chance
Yeah.
that there could be a copy number variation, or there could be an ADP-KD or things like that, and I don't want to take that risk, I want to terminate. Is she well within her
I will
rights?
counsel and
Yeah,
recounsel,
no,
but
we-
then,
we counsel.
yes, I will do it for her.
And if she says that she is not willing to do any kind of test,
But still, she has the right to choose that before
she has
20
the
yes,
right to choose.
that is a very important point to say, because we should always respect the woman's right also here. So yes, we counsel them positively, and that's where our counseling becomes very important, because when she weighs our counseling versus what she read from Google, it depends on how confident we are in counseling. So if we are wavering around the iffy mark of, like, say, maybe, may not be, then that is where the problem arises. From this scan, it's very clear that this kidney looks good. CMD is maintained, Liker is normal, volume is good, the bladder looks fine. As far as we are concerned, right now this baby is good. We are doing these tests to rule out those rare causes. These are not common causes that we are talking about. We rule out those rare causes that could affect this kidney.
Yeah.
And when we counsel them, that is the way we should counsel. Saying that most likely we are looking at good outcomes. There is a small possibility that there could be something wrong, and for that we need to do these tests. On the other hand, if we emphasize on the abnormalities and say that we need to do these tests first before we can say that the baby is entirely normal, so we are pushing them in a different direction. And so that counseling usually comes from the obstetrician rather than the fetal medicine person, because they will come back to you for counseling. They will come to us, they'll take the report, but they have no bonding with the fetal medicine person. The fetal medicine person is the person they're seeing for the first time. Their bonding is with the obstetrician, and she will trust your word. So it depends on how confident you are and how confidently you counsel the patient that this patient will take the decision of doing a test and continuing the pregnancy. But at the same time,
Vijay,
in fear,
just to complete,
yeah, yes.
after a positive counseling, in this particular scenario, if they are proceeding with the termination out of fear and not willing for antenatal procedure, I think it's part of the obstetrician's responsibility to at least convince them for a DNA storage from the post-abortal specimen. You can discuss that with the fetal medicine, what can be the best one, because if it's going to be a normal variant, she can still have it next time. So it becomes endless.
Absolutely.
And if it's genetic, it can still recur. So we need some answer.
And also, this similar scenario happened with us also. When it turns out to be normal, she does a post-delivery sampling, and it turns out to be normal, we should not victimize the patient. Because many times these patients come back to us saying that, okay, we had an echogenic kidney last time, we did a postnatal sample, everything was normal. So the wrong thing to do is saying that you unnecessarily terminated that pregnancy and burden her with that guilt as well. So whatever happened in the past should not be discussed and should not influence the outcome unless there is a report that tells us that, okay, it can affect their pregnancy.
Okay, so in this particular case, the couple were not that well informed. They didn't come with a decision. They were not expecting this in the first place. So then they asked me, what would you have done? That's a very common question that gets thrown back to us. If you were in this place, what would you have done? So what would we advise them? What can they really do next to risk stratify this particular finding on the ultrasound scan?
As I said, to start with, the chances quite good in their favor of a normal outcome, and a systematic stepwise evaluation when keeps coming back as normal, would keep increasing the chance in their favor. As we know, in most of medicine, we are not going to hand over a 100% guarantee.
Okay.
But if they are able to understand the limitations of the science itself, then I would say that once we come back with the CMA report that says normal, then that's a big relief, because
So you would definitely do an amniocentesis.
I would.
Case. Yes,
And-
all of us agree?
And then I would
I
re-examine.
beg to differ.
Yes.
For all echogenic kidneys, no, because we know that there are other variants also. I fully agree with you, but it is one part of arm in this scenario where you have to offer amniocentesis, but still without amnio also, I think we can follow this up after 2 weeks to see how the kidneys, the bladder, the liquor looks like. Because if it is an evolving luto, then we know that it is not going to affect the plan here.
No, but the problem there is she's 20 weeks,
It's
3
an
days.
Fair enough,
enhanced
still we have,
CMD.
yes.
I wouldn't expect a luto in an enhanced CMD. The opposite I would
Okay,
expect.
still I agree, but the liquor is normal, maybe 2 weeks time frame, the kidneys are fairly normal. Still, amnio can be offered, but I don't think I'll put it at the top of the list.
Let's put some examples, real examples. Genetic dysplasias.
No, this case
including-
definitely there is something genetic which you know, that is why she is
congenital
pushing it
nephrotic
there.
syndromes would keep going normal only. Whatever you are mentioning, ultrasound will keep appearing normal. The only way to go there is, only way to different. For example, 17q12, most common genetic variation, chromosomal aberration, would keep seeing normal only. Only after birth we will get to know.
How many
Fair enough,
17q?
fair enough.
Yes,
Let me
fair
cut in there.
enough. Just
Right,
let us leave it there.
we agreed, okay? We agreed that we will do the
Let us do,
amniocentesis.
let us do.
So now, what test in the amnio?
You have written all this.
All of this?
KT,
No KT.
CMA.
No
No
KT.
KT. Take away KT.
Okay.
When you're doing a CMA, take away your KT. Maybe QFPCR if Manigandan is worried for a week to find out a trisomy 18 in this echogenic kidney. Fair enough to have a QFPCR. Then a CMA, of course. DNA store, okay. Panel of for what? Echogenic kidneys. Huge list.
No, he
Wes?
is asking panel or VES.
Yeah.
Always
Both
less in
no, both
prenatal.
no. I'll go with my CMA first, look for the common things are common, then decide about
Okay,
Wes.
so let me just put this in perspective.
Without a trio, without an index case workup, I am not going to go beyond CMA in this patient.
Okay,
No.
so you will not offer a
I will
gene
not go
testing.
straight to S or CS in this patient straight away because if I get a VUS, I'm going to be in trouble. I don't want to hear.
So how is it in the UK? Yes.
Am I allowed to differ? I will reassure the woman and send her home.
Yes.
Okay. No testing at all.
He's protected by the NHS comprehensive plan, I think.
But I'm nearly close to him, but I'll do an amnio, but not go anything beyond that. Wes and all is not at
Can
all
I
in my list.
justify my,
Yes,
Yes.
please. Yes.
my statement? So, what are we looking for? We are looking at bright kidneys, right?
Yes.
Okay. How bright is bright?
Okay.
How long is my nose? It's subjective, isn't it?
All right.
So, is there anything else which would justify our suspicion that there is a chromosomal abnormality?
Okay.
So, if you are seeing something else, if we make a diagnosis or suspicion of uncommon problems commonly,
Yes.
we will be incorrect commonly.
Yes.
It's only rarely that we will be correct.
Right.
Okay? So the suspicion, the doubt that women have or couples have is to a large extent driven by us, as what we say to them will decide. We make them uncertain, then obviously they will be scared, isn't it? So that's not our job. Our job is to say to them what we feel is the underlying problem. So if you're looking only for, let's say, copy number variations or whatever it is pretty uncommon. Yes, so if I don't know of any common genetic, or rather not genetic, chromosomal abnormality where bright kidney is the only sign that we see.
Yes.
So on that basis, I'm going to say to them that, look, it is possible that this baby may have something or the other wrong.
Yes.
But if you are accepting a chance of getting pregnant, you are accepting that risk.
But are you bound by a 24 weeks termination limit like we are here in India?
No.
We are, but where is this question of termination coming from?
No, yes.
Okay. Can I also differ?
Yes.
Yeah, please.
of course.
Okay.
That's what we want you to do.
We won't go beyond the
So
first case.
But keep a look at
let's
the time
answer
as
the
well.
first question. Yeah, I
Yes.
saw that. Let's answer the first question. How bright is bright?
Yes.
For kidney, it's very clear. You have to match liver echogenicity.
Yes.
If you are brighter than that, you are bright. Then you ask whether the cortex is brighter than the medulla more than usual,
Yes.
or it's the reverse, or it's the same. So there is no difference in that.
Right.
It's like defining echogenic bowel.
Yes.
Even though it's subjective,
Well,
you still have
let's not get to the
something.
merits of the
Correct.
individual findings. The point I'm trying to make is
No,
if you
no,
decide.
I was just answering, sir.
I
that
understood. But we have
are-
to press by time. Yeah.
We have to accept that.
Yes.
And in our own series,
Yes.
we have found out that 17q12 is the largest player.
17q12 deletion.
Microdeletion syndrome.
Okay.
Presence with because these data are new, and the more you do CMA only, you will find out. If you don't keep on offering.
Okay, so if I
you're not going to
agree,
find out.
if I agree with your point for discussion's sake that you are allowed to do an amnio, would you just stop with the microarray or would you go ahead and do the full panel?
Of course, I would discuss that.
Yes.
I would say I have a small chance of finding CNB. If it comes out negative,
Yes.
based on your pedigree and your consanguinity, your chance of having a autosomal recessive genetic dysplasia is even rarer. Do you want to go for the West? Comes with the
But
cost.
where do you draw the line? 24 weeks is the cutoff that we have.
No, if you have a genetic problem,
Yes.
and if it turns out to be bad, there is no 24-week cutoff. I live in a city where my next door is medical college, who are the medical board, and we give a post-test counseling. They will be happy to terminate within the legal framework.
Okay. So you would want to offer a West
Yes.
in a sequential
detailed
manner.
everything will have a detailed discussion, the pros and cons, and then it will be offered.
Yes.
No.
So we have a
Anyhow,
divided.
we have a
panel.
want of time. I won't disagree now, but I totally disagree that I will not offer a West in this patient. Let us go with the
Yes.
next case.
All
We'll
right.
sort it out outside this
Till
room.
the case which has backfires
yes.
will not.
No, that could be a very odd case, like Professor Bide
Anyhow,
said.
you are
It might
storing
be
the DNA.
Very unusual for you to come
But sir,
across.
just a query on this. But there was a paper from St. George's which looked at echogenic kidneys and their prospective analysis, if I remember correctly.
Yes.
I think it's from your center only. 2 years back, they had published a report, a paper in the White Journal. And in that, if I remember correctly, the idea was to offer testing. And if they did not do a microarray, but they did offer testing. And if they found that it was normal, they said that there was a 10% chance that there could be other genetic disorders. And there was a list of disorders that was listed out. I think the most prominent among them was ADPKD or something like that.
Yes.
I don't remember exactly, but that was in that list. And in the last algorithm that they published in that paper was to offer invasive testing and to confirm that there is no aneuploidy. And if these three things were normal, Leica, size, and one more thing was there. I forget. No.
Associated anomalies.
No, Leica or something else was there. There was a third point, which all of these three things were normal. And if you found that the amnio was normal, you could counsel positively. And I think the incidence was around 75 or 76% for good outcomes without anything. If you don't test, you're looking at 75 to 76%. I'm not sure if you.
That's what I said. We start with a 7 out of 10 in favor.
All right. So, anyways, this case we did offer an amnio. They took it up. CMA was normal. We didn't offer the whole exome at that point. Torch was negative, but at 23 weeks, the kidneys look exactly the same. They're still echogenic. So now they come back and again ask the same question. You said the chromosomes are fine. We agree, but the finding has not gone away. So it's not a transient finding. It's a persistent finding. And now you say if I do a whole exome sequence, it's going to give me a result in 6 to 8 weeks. By then, I can't decide anything. So do we go all out or do we just decide, let them terminate if they wish to at that point in time?
So originally when we discussed, if they had agreed that we will do only CMA, at this point that will be brought in and we say we agreed this much evaluation that has come negative and therefore your starting chance of a bad outcome has now decreased even further, provided that except for the echogenicity, rest is going well. So we can reassure them to that extent.
Fair enough. So I think we still have an uncertain prognosis here because you still have not done the entire...
The uncertainty keeps decreasing. So that's fetal medicine is all about that, isn't it?
So
like Sir pointed out.
So by 24 weeks, but within the time limits, whatever is possibly ruled out, so the odds of having a better outcome is even better than what we started off with, is what you're trying to say. Fair enough, because you cannot get the results of a whole exome sequencing within the stipulated time frame of 24 weeks. Yeah, so we would counsel them positively at this point, not advise termination. We'd say probably your chances of getting a good outcome are even better than when we started off, right? Okay. So shall we move to the second case because you're running short of time? Yeah.
We are not taking a vote on what to do for the last case because it's obvious that all of you are divided on what to do. So we'll go on to some area that probably will have some concurrence. So we're looking at a mother who was referred for FGR at around 24 weeks, 2 days. She was diabetic and there's a maternal history of seizures, but she was not on any medications right now. She had a completely normal combined test. Her PAPA values were pretty normal. Uterine artery was normal. There was no increased risk for preeclampsia, and this was her finding. She had a very small baby. All Dopplers were normal. Okay. And she was counseled for termination before she was referred to us. The idea being that her dates were correct. There's nothing wrong with her dates. She's an ophthalmologist herself. So her treating physician told her that since this baby is very small at this point of time, there is very little chance that this child can reach the period of viability, and was told to terminate the pregnancy. Okay, she was a primi gravida. So how will you counsel this patient? I'll start with the obstetrician and then we can take the fetal medicine input.
The baby is small.
Very small.
Very small. Because the abdominal circumference is less than the 5th centile.
Yes, the entire estimated fetal weight is also around the 3rd or 5th centile, in between that, hovering around that lane.
Do we have any scans done earlier?
After
was that all coursing on the 5th
no,
from the
she
beginning?
had the NT scan and then she came directly for the anomaly scan.
Okay.
She was a low risk mother, which is not low risk entirely, she was an overt diabetic.
Yeah.
But apart from that, she had nothing going against her.
Yeah, so I'll screen her for, her glycemic status. And she probably, I don't know how long she has had the overt diabetes. Does she have a vasculopathy which will account for this?
Yes, yes.
Go through all that. And then the question is, will this baby survive?
Yeah.
So you can't say at this stage.
Okay.
Because it is small. It is not what we normally see. And therefore, the chances of the baby having an IUD is there. But at the same time, terminating the pregnancy at this time, just for the sake of growth, is not applicable.
Okay, I'll ask you the exact same question that she asked me. She told me that yes, this baby is small, nothing is going wrong with her. This baby, her or him, whatever. And this baby will go across maybe for some more period of time. But what she was worried about was, if you reach a stage of say 29 weeks or 30 weeks, and the baby is severely growth restricted, and you have to do a cesarean section to save that baby, will she land up with a baby that is handicapped? She was worried about that because she's saying that this baby might not reach the period of viability. She may reach somewhere around 29 to 30 weeks. You may be forced to do a cesarean section. This child may come out and be in the NICU. Isn't there a strong possibility of this child having, neurological damage
Yes.
or some other sequelae related to prematurity. She's an ophthalmologist, she's very
Yes,
well read,
yes.
and she didn't want to take that risk. And she asked me, if wouldn't it be better if we terminate this pregnancy right now, and for the next pregnancy, let me get myself worked up properly and start off myself on aspirin and heparin or whatever indicated, and would I have a good chance of having a normal child? What do you say to that?
That is
A very difficult question
very
to
difficult
answer.
question.
Anybody else wants to take that question?
Be honest and say, I don't know. At this
Yeah,
point, I really
that's-
don't know. But this baby needs to get worked up. Why are we even talking about termination to this family? I don't understand.
No, we are not
She's
talking.
asking-
She has
asking,
come.
if she is asking,
Ah.
it is our responsibility to tell this woman that this baby is structurally normal. Whatever we are seeing is a small baby with normal Lycra and normal Dopplers. This may be this baby's own growth potential, but I still want to go by algorithm where less than fifth centile. Here is one baby where I'll offer her invasive testing definitely.
You will offer all of
I
you will
will,
offer,
I
sir,
will.
sir, you will offer invasive testing.
I will here
Okay.
because the Dopplers are normal.
Because the Dopplers are exactly. So if the Dopplers were abnormal, would they come? Okay, good. And if the Dopplers were abnormal, will your counseling change? Small baby, 24 weeks, absent and diastolic flow, singleton pregnancy.
But as you said, the timing of delivery and all those things may still, be preterm, but the outcome may be better in a small baby with an abnormal flow, usually, because there is something intrinsic with the placenta there. And in a
No,
baby where there's
at
Doppler,
24 weeks, severe growth restriction, absent and diastolic flow within
depends
the
on
umbilical
your
artery.
NICU, that is what it is. If you have,
No, however good the NICU is,
Yeah,
if she is
24 weeks.
asking you that this baby is having absent and
why are we
diastolic flow,
delivering her now at 24 weeks
not
with absent
delivering,
and
I'm
flow?
saying that she doesn't want to continue the
If she
pregnancy.
doesn't want to continue pregnancy, that means a termination of pregnancy,
Yes.
right? So then there's no point in talking about the outcome here.
No, I'm asking you if this patient had absent end diastolic flow and if she wanted termination, will you be doing that, or will you say no, let's wait?
No, if she is asking, as we said previously also, it's her right.
And okay, fine. And also you will not test her.
I will tell her to test.
For absent end diastolic flow, small baby, you will test.
All absent endosteric flow is not placenta. Majority of them are yes.
So-
But if
so-
she's terminating, then I have the baby
So
to
out of
test.
10 patients, you will test for 8 because majority of them.
No, antenatally, Bijoy, let us conclude saying that if the
Okay.
baby is normally grown with a normal uteroplacental blood flow, I test antenatally, definitely. If she is terminating for her own risk, then I may not test her antenatally, do a postnatal CMA
Okay.
and look at the
Okay,
rest.
so to the fetal medicine people, uteroplacental insufficiency, baby is small, umbilical artery showing absent and diastolic flow. Are we justified in testing?
Generally, no.
Generally,
If
no.
the
So
baby
what-
looks clean,
Yeah.
and
With normal
we have
baby,
evidence
ultrasound,
of,
yeah.
we have evidence, strong, incontrovertible evidence on placenta being the cause for the smallness.
Better not.
I wouldn't
You
test
can
it.
leave it at that. Now, my question is: you have a small baby, structurally normal, scan is absolutely fine. There is no signs of aneuploidy. Nothing is there. Clean baby. Dopplers are normal. You're offering testing. There is no polyhydramnios. What test are you going to offer?
If we are talking about this case, Bijoy, if you go back, it's the AC and the FL, the markers of nutrition are smaller.
Yes.
So in this case, I would still think down the line, at some point, I will get the evidence that it is placenta-based smallness.
Agreed.
Having said that,
What test? Yeah.
I would introduce the concept that apart from placenta, there may be genetic causes of failure to thrive, which may manifest now in a similar fashion. And I don't have the armamentarium to completely exclude everything on earth that can result in a failure to thrive after birth due to a genetic cause. With that, probably we would start with the CMA.
Okay.
Not more than that I cannot offer. If real things to do, studies, we can't. So
Okay.
it's not really,
So,
the yield
sir,
is
you
low.
will agree with that, or
Flex, West can be offered as a trio, but I generally refrain from that.
Sir, what would you offer if you are doing invasive testing?
So the picture that you showed me, it is not fitting into placental problem. So there are only 4 reasons why babies are small. Only 4 reasons why babies are small: dating problems, nutritional smallness, placental problems, and primary fetal problems. Okay. So dating problems we already excluded. We've got
Correct dates.
constitutional smallness is the smaller the baby, the rarer is it is likely to be constitutional. So that leaves us with the other two. The picture is not fitting into placental issues. The baby to be so small, so early, we must have Doppler, particularly uterine artery Dopplers should be abnormal, and we are not seeing that.
Nothing.
Having said that, apart from just looking at the size of the baby, we should look at other features also. How is the placenta looking? How is the fluid looking? How is the baby's heart looking? Is the heart big?
Yes.
All these features we have got to look at, and it's not fitting in. So that makes me suspicious and worried in equal measures that there's something else going on.
Wrong going on. Okay.
And that's the reason why, if the woman wants to terminate, I think I would support it, and I would have the same kind of anxiety because we may never find what is wrong.
Okay. So, but let's say we are offering invasive testing, because the other option to termination would be to try to find out antenatally what's going wrong. So, what test would you offer, or how comprehensive can you ever get at testing?
So there is no test for normality.
Yes.
We know that. So in the UK, it's not as simple as me saying that I want everything done.
Yes.
And that's not allowed.
Yes.
So what I am allowed to do, ask for is a amniocentesis with QFPCR and microarray.
Okay.
Anything beyond that, we will need genetics input, and this evidence that we have got is not sufficient
To do
justify.
that. Okay. What would you test for, ma'am? Good Dopplers.
CMA, and then I finish maybe a Targ because this baby is very small, because I'm putting in a needle a Targ PCR plus, but there is no scan findings for infection. Definitely a Q of PCR.
Now the problem with us and probably the management in UK is going to be slightly different here.
Yeah.
Because we have no dearth of labs that are ready to offer you all the tests available.
No, I'm not going
And
to
we
go
have,
beyond
wait,
CMA, no.
let me explain. And we don't have any shortage of genetic specialists who are willing to report and explain to us the whole thing.
Yeah.
The patient is willing to pay from her pocket for all kinds of testing. We are not funded from anything. She wants a clear-cut answer. Is this child normal or not? If not, if you're doing a microarray and if you're saying it's normal, I will continue. But is there any other test that is available that will make me a little bit more confident?
Vijay, as he rightly mentioned, there is no test in the world which
There is no
there's no
test.
test for normalcy.
I
right?
agree. I totally agree
So we
that
have
there
to
is no
stop
test.
somewhere for normal
I
solving.
totally agree that there is no test for normalcy. But have you tested your limits is the question. If you have reached your limits, and if you have reached a point where you can't
What
say
is that
further,
limit? Can I
yes,
just get it from you?
Is there a limit, Manikandan, for this?
To trio? No,
No.
but I won't agree with that. I'm going to go with the trio here. No KT, just array. Wait for the report of array. Rescan her after 2 weeks to see how things are. No exome at this point of time. No.
Okay. One of the amongst the rarer genetic syndromes of failure to thrive, one of the things that can usually come across in a apparently normal looking baby with this kind of a picture, that is, the head is okay, but the trunk is small, which mimics like a nutritional problem, is a Russell Silver. And you can't find it by
You can't find
CMA,
it on
you can't find it by WS,
It's an
you need
imprinting-
methylation.
it's an
So
imprinting disorder,
you're
yes.
not going.
No,
So
yes,
as you rightly pointed, I would, if it comes to testing, I would involve the geneticist. We don't have in-house, so what? So we can do a Zoom meeting and let them decide between the geneticist and the mother to what extent they want a testing.
I think the point here is what testing is available and what resources you have. If the patient is willing to
And what is the
explore-
yield of such a
Yeah,
testing?
and if the patient is willing to understand the risk and explore all those resources, then we should use those
Just
resources.
because we are not practicing health economics doesn't mean that the NHS is practicing the same,
No,
but
no,
we are
I'm
not just offering everything
I'm
under
not,
sun.
I'm not arguing with NHS. What I'm saying is, what we wanted to offer this patient was what was available for us to the maximum limit,
In the
so that we
same
can
path,
say,
the same, when you take an amniotic sample, you offer everything the same batch, or you wait for your primary thing
thank
and
you
then
for that
come back?
question. So what we did was we did a test called as Exome Plus. So this is a new test on the block which looks at both microarray and whole exome sequencing in a single shot. The cost is exactly the same as a microarray, and the resolution for this test is much more than your normal microarray, which is only 750K. So we have a resolution of 1000K for microarray, and we're doing a whole exome sequencing, a single test that would cost you the same as microarray. So I'm putting the question back to you. The amount of money you have to spend is the same. The sample you have to do is the same, but you're going to get much more information with this test. Would you want to do it or not?
No.
Why?
That
No,
much
because
more
common things
information
are
can...
always common. I believe common things are always common. I'll do a QPCR, CMA, and then go for my second step test. No.
Sometimes
Okay.
the much more
Because
information can
every
be a
day
little too
we see
much.
small babies. How many small babies are 16p? How many of them are Russell Silver? How many of them are other genetic rare single
True,
gene?
Okay.
true.
Very
Okay,
rare.
we will leave that
No, it's true.
discussion.
That's the point. The a priori risk is always low.
Okay.
Even though in this case it looks small, it's 500 grams, 24 weeks. But the a priority of getting in a clean baby, the background chance of it being genetic is always small.
Okay.
So if you pass it out, you will still escape through in many of the cases.
Agreed. Okay, so the consensus here would be offer microarray. You don't want to do an exome sequencing. I would differ on that because I would prefer to get all the information at hand and to go to whatever extent possible so that I can reassure the couple. But there is a false side to that. The time is up. Oh my God. Okay, just this last point. This is what came out on her exome plus. She's got a pathogenic variant for a
We have 5
mitochondrial
more
gene.
minutes, actually.
By the way, I wanted to tell you there were 6 mutations that came out, of which this was only pathogenic.
So that's the point I was trying to make.
Okay.
When you say it gives you much more information,
Much
sometimes
more
much more can be too much, and you don't know what to do with it. You get
That's
stuck.
right. That's why at the beginning we should involve
Counseling.
the geneticist.
Geneticist,
And
counseling is very-
mitochondrial prenatally no.
The geneticist will very clearly tell you, test what you can explain. Only test for those things that you can explain if you find it on the report. If you find a report that says there is a mutation, you should know, okay, this mutation is going to cause this. Otherwise, don't test.
And so what?
No, it's not lucky because see, go back with Vijay. 27% heteroplasmy.
Heteroplasmy.
Nowhere you're going to explain whether that's going to affect the child
Yes.
or not, whether it is the mutation may be pathogenic, but any mitochondrial you cannot be sure. Even
But-
if it says 100% heteroplasmy, that's only in that tissue that you have tested, which is amniocyte.
So
What happens in...
So the problem
Yeah.
here is you get something that you did not test for.
Correct.
But there is an advantage here also. What is the advantage here? No, we continued, absolutely, that's where you're wrong. We continued the pregnancy in spite of a pathogenic report because we told them that this is a report that does not have significance. We tested the mother carried the same mutation, which means the child was absolutely normal, and we continued that pregnancy, and she had a baby that was alive and well. So the point here is, at 27 weeks, I was able to reassure the mother that we tested everything under the sun. We tested everything that was possible. We found that the child was normal. We found a pathogenic mutation. We still continued the pregnancy, and she has a live, healthy baby because we used our resources. I think that's
Also,
the point here.
the point that should go is when we highlight one case in SGA babies that comes back as a pathogenic variant and that too non-actionable, then it drives the point, I'm afraid, that we have to test small babies.
Correct.
I would say...
Not all.
Hold on.
Yeah.
I would say be very clear and let it happen in the counseling room of a fetal medicine specialist along with the geneticist rather than in the obstetric OPD. That is the point I want to say.
The point here is you need inputs from everyone. This is not possible from just a fetal medicine perspective. So I don't believe that you should be scared of what you will find and stop searching. I feel that you should search and find whatever there is possible and make sense of the results that you have got. To make a simple story short, when we started out doing fetal medicine, everyone was afraid of microarray. They would always say, do karyotype first, and then do microarray. Now microarray has been pushed back stage, and now they're saying do microarray. So the thing is, the more we know about these genetic mutations, the more we learn, the better we will be at counseling these patients. But never attempt to counsel without help. And I think at least in Kerala, we don't have that excuse because we have help everywhere. I don't think there is any other state which has so many fetal medicine specialists and so many geneticists in every district. So I think there is no excuse for us to not use their help. Because if you do, then you'll definitely save babies and we would never have to talk about borderline findings. Thank you, panelists, and sorry for he had a lot of cases, but I don't think we have time for much. Thank you very much, and thank you Vidya Lakshmi ma'am for spicing things up.
Thank you so much, Bijoy, Vivek. As usual, you gave us good cases, and thanks for the advances team for having us here. And And I really enjoyed being here with my co-panelists, including my teacher, Dr. Sankita Menon, and Dr. Binde and Manikandan, all of them. No, including Manikandan, I said. I didn't say that you are my teacher.
Thank you,
Yeah.
panelists and the moderators.
Thank you all.
Thank you for the such an truly engaging and dynamic session and discussion, and thank you for sharing all your passionate views. And this shows that how a woman's health can be truly shaped in. Thank you once again.